We started initially with 3-year-old children, and then we went up to, that's one clinic of mine, that's a spectrum of age that I get in one clinic, wide. That's another clinic in another center. Look at the spectrum of age. All of them get corrected by Ponseti's method. They do not need surgery. I would say the choice between surgery and untreated leaving it alone is clearly leaving it alone is better than surgery. The long-term results are far better in those cases. Initially, we were doing it only in 2 to 3 years age group. We did the full thesis protocol on this, 2003, followed them up, results were beautiful. Including X-rays, they were beautiful. Then we attempted to try them in the older patient, and we are now using it up to 12 to 14 years. So what are the things? Problems in evaluation, problems in manipulation, casting, tenotomy, bracing, outcome and follow-up. Let's look at evaluation. Pirani score is validated for the younger child, but we can use it for the older child also. We should know what is not reliable in this. What is not reliable is the creases are not reliable. Middle crease, posterior crease not reliable. What is not reliable is the empty heel sign is not reliable. What is reliable is curved lateral border. What is reliable is the talar head. What is reliable is the rigid equinus. So 3 components are reliable, 3 components are not reliable. There is an older patient score which is called the Pirani-Baum-Sinclair score, PBS score. But Dr. Pirani himself doesn't recommend it, so I also not going to recommend it. Manipulation, you will need to use the 2-hand method. One hand is difficult. You saw that in trying to do it in the model also it was difficult. Okay, so you do a 2-hand. So in the older patients, heavier cast is required. They might come with a broken cast, and you need to keep the cast not at 90, at 40 degree. Remember I told that mother 40 degree cast. At 40 degree, you can walk with a sandal like that, and an equinus child can walk and go to school. It doesn't have to miss school. One at a time you can do. And this child came, they'll come back with broken cast. That child said, the father said he comes with a broken cast. So you put this and put the child on synthetic cast. So I share one roll of bandage between 2 or 3 children and manage it like this, and it works beautifully. The other problem is frequency of casting. There is some literature which talks about 2 weekly change. There is no need to do that. 1 weekly change of cast is sufficient and you can do well. Tenotomy, no issues. Closed tenotomy, you already seen the results. I would do only a closed tenotomy. There are no clear guidelines on this. However, you would be worried about medical legal cases कि हमने इस एज ग्रुप में कर दिया टेनोटमी, क्या होगा, किताब में नहीं आया. Don't worry. All the literature that you can copy that, all of them are more than up to 9 years. Up to 9 years, you do have support for tenotomies. But you've seen the results and it works beautifully. Up to 23 years also, you can do it. You've seen this slide, I'll skip that. Bracing, we don't know the answer. Today's protocol is at night, give a foot abduction brace. Rest of the time, do a hinged ankle foot orthosis. Hinged ankle foot orthosis. We give it all the time, the older patients also. Sometimes we recommend early tibialis anterior tendon transfer to prevent them from going on to braces. So earlier tibialis anterior transfer is recommended. So we don't know what are the problems in long term, we don't know the actual reasons, but there will be children where those are the results. Quickly you can see that 11-year-old girl, unilateral clubfoot, already operated, treated by Ponseti casting alone, nothing else, just tenotomy and Ponseti casting completely corrected. What is not corrected was the size of the foot. So older patients, when they walk, you can't get the foot to be same size if they are unilateral. Counsel the parents on that. Okay, and unilateral, the callosities, you don't need to operate the callosities, they will drop by on its own. So this callosity that you are seeing here will drop off and will become normal skin. Counsel the parents, it may take 6 months to 1 year, but it will become alright. But they won't stand on tiptoe within 2 months or 3 months, they may take 5 to 6 months for standing on tiptoe, but the size difference will remain. Bilateral, that is not an issue. Bilateral feet, you can correct it nicely, fully corrected. Hind foot valgus, For to avoid a long term bracing, I did a tibialis anterior tendon transfer. See that? That is the tibialis anterior tendon transfer that I have done, but I mistook the length. When you are doing the transfer, make sure you take the tendon all the way as distally as possible. Otherwise, you will not be able to put it into the lateral cuneiform. It will fall short. So, I fell short and I had to use a 3 incision technique. I did not like it. That is the bowstringing effect which is there, but you can avoid it by being very careful in your dissection. So, the bottom line is try Ponseti in all children, including operated cases. See the extent of surgery, severe deformity, Ponseti method, no surgery done, only tenotomy surgery done, got corrected completely hindfoot valgus. Can you see that? Nice hindfoot valgus, completely corrected just by Ponseti casting. He probably had 12 casts. Now, I will give a hinged AFO and nothing else. They will have recurrence, recognize them and treat them with 2 or 3 casts and they will do well. That is it. When would I not do Ponseti? In these cases. They will recur in these cases with total tarsal coalition. It will not work. You need to do an osteotomy. So, bottom line is try Ponseti in all, it works and gives you good results. Thank you.